My name's Joanne Horning, and I'm the founder and executive director of the San Francisco Bay Area affiliate of Susan G. Komen. Thank you for joining us for the fourth presentation of our educational web series featuring monthly discussions focused on current breast cancer issues and presented by prominent Bay Area physicians and researchers. This episode was generously underwritten by the McKesson Foundation. I am pleased to present Dr. Wei Wang, Medical Director of the Cancer Genetics Program at California Pacific Medical Center. In this episode, Dr. Wang will discuss fertility preservation options for young women with breast cancer. At Susan G. Komen, our goal is to save lives and end breast cancer forever. Thank you for joining us.
Thank you for the opportunity to discuss the topic of fertility preservation options for young women with breast cancer. This is Dr. Wei Wang. I'm a medical oncologist practicing in San Francisco. In my clinic, I frequently see young women with newly diagnosed breast cancer. They are often overwhelmed by a new cancer diagnosis and the protracted treatment involved, such as 6 months of chemotherapy. Some of them have added stress of having to make a very personal decision of childbearing in a very short time frame, which they haven't had to face in their lives up to that point. In the United States, cancer in women of childbearing age younger than 45 is not uncommon. The latest statistics from American Cancer Society showed in 2014, out of 230,000 plus new diagnoses of breast cancer, 25,000, about 11%, were in women under the age of 45. One study showed up to 50% of these young women of childbearing age wish to preserve their fertilities at the time of their breast cancer diagnosis. There are competing risks and concerns of young women with breast cancer. Breast cancer is the leading cause of cancer-related deaths in women younger than 50-year-old. The tumors are often more aggressive biologically, and the chemotherapy is often recommended. Chemotherapy can cause menopause temporarily in all women, and some will sustain permanent menopause as the result of chemotherapy. There are a number of negative consequences of premature menopause, including infertility, accelerated bone loss, hot flashes, mood changes, and sexual dysfunctions. However, we do know from a number of studies, early menopause from chemotherapy may improve long-term prognosis of breast cancer treatment. Over 80% of breast tumors are estrogen receptor positive. Anti-hormone therapy is a critical part of breast cancer treatment, and the duration of the anti-hormone therapy can be up to 10 years. As a result, pregnancy during that time is not practical or recommended. The most common questions that I hear from these young women with breast cancer are, what are the fertility preservation options for them? How well do they work? Would they interfere with their breast cancer treatment, i.e., are those safe? And how many years does a woman have to wait after breast cancer diagnosis before attempting pregnancy? I will try to address each of them today in our discussion. Let me start with a fairly typical case. This is a 35-year-old woman with a locally advanced breast cancer. The tumor in the breast is fairly large, and there's a biopsy-proven positive lymph node. The tumor cells are estrogen receptor positive, progesterone receptor positive, and negative for HER2 overexpression. Her treatment involves 6 months of chemotherapy before surgery. She then underwent bilateral mastectomy, followed by post-mastectomy radiation. She is currently undergoing anti-hormone therapy for anticipated duration of at least 5 years. When she was first diagnosed, she was just engaged. She and her fiance very much wished to start a family at the time. So what are her fertility preservation options? Before starting chemotherapy, she could undergo standard in vitro fertilization, IVF procedures, and freeze down embryos. For women who do not have a partner, egg freezing is also possible and is considered standard recommendation. During chemotherapy, one approach is to undergo a monthly injection to suppress the ovaries and to reduce the risk of premature ovarian failure because of chemotherapy. This approach was felt to be experimental, but now is more widely accepted with more recent data. After chemotherapy for breast cancer, natural conception is always preferred. The frozen embryos and eggs can also be used to attempt pregnancy. The American Society of Clinical Oncology updated its last guidelines in 2013 on fertility preservation. It recommends discussing and addressing fertility issues as soon as possible before any systemic treatment starts. For any patients who's interested in IVF, they should be referred to IVF specialists. The guidelines recommend freezing of embryos or eggs as an established method for fertility preservation. It considers ovarian suppressions as experimental at the time because of insufficient evidence regarding its effectiveness. Fertility naturally declines with aging. This graph shows that the optimal time is before age 30. After 30, particularly after 35, there's an appreciable drop in pregnancy rate. Chemotherapy may cause premature aging of the ovaries. One estimate suggests a 10-year advancement in ovarian age after chemotherapy. Compounding the issue in breast cancer is the anti-hormone therapy that's as part of the breast cancer treatment. The duration of the anti-hormone therapy can be up to 10 years. One trial done at UK showed 10 years of tamoxifen treatment rather than stopping after 5 years, significantly reduces breast cancer recurrence or death from breast cancer. In that study, 19% of the patients were at age 45 at the time of starting tamoxifen treatment. In the United States, a recently published SOFT trial showed that in young women with high-risk breast cancer, ovarian suppression for 5 years, making that woman postmenopausal during that 5-year period, improves long-term breast cancer outcome. Because of these reasons, IVF and embryo freezing before starting breast cancer treatment is one of the standard recommendations for fertility preservation. IVF entails stimulation of the ovaries with hormone injections to produce multiple mature eggs. These eggs can then be surgically retrieved from ovaries, mixed with sperms, and fertilized, matured in a petri dish for 3 to 5 days, then freeze down for later use in breast cancer patients. IVF often requires 2 to 6 weeks. The hormone injection ideally should start soon after the next menstrual period starts. Although more recently, a random start anytime during menstrual cycle has been shown to produce significant number of mature eggs. Sometimes 2 rounds of banking may be required if the ovarian reserve is low. So it takes minimum of 2 weeks. Sometimes it could be critical in breast cancer treatment. The cost is anywhere between $12,000 to $16,000 per IVF cycle. And to make an embryo, the woman needs to have a male partner or a sperm donor. The most data come from the IVF clinics around the country. The Society of Assisted Reproductive Technology, SART, published its data nationally on its website. The most recent data from 2014 shown here demonstrate that the live birth rate depends on the age of the woman. For those younger than 35, live birth rate exceeds 50% but declines rapidly with age to single digit after age 42. For women who are unsuccessful using their own eggs, donor eggs from women generally younger than 30 can result in a successful live birth. In this graph showed the success rate is close to 40%. The largest series of IVF success rate in breast cancer patients was published last year. A total of 131 women with breast cancer underwent IVF and embryo freezing at the time of diagnosis with a median age of 36. After a more than 5-year wait for their breast cancer treatment, out of 131, 33 returned to undergo frozen embryo transfer. 18 women had frozen embryo transferred to self, resulting in 9 with a successful delivery. 15 actually had an embryo transferred to a surrogate carrier, also resulting in 9 deliveries. So out of the 33 women who returned for embryo transfer, a little over 50% had a successful delivery. And this number is comparable to non-cancer patients in a fertility clinic. However, if we look at a total of 131 patients who underwent IVF at the time of their breast cancer diagnosis, only 13% had a biologic child from this approach. Half of them had to use a surrogate carrier. The use of surrogate carrier has become an accepted practice for many women who cannot or should not carry a pregnancy to term. Therefore, undergoing IVF and embryo freezing before chemotherapy for breast cancer and engaging a surrogate carrier would allow patients with breast cancer who have estrogen receptor positive tumors to increase the duration of their anti-hormone therapy to the recommended 10 years, while at the same time starting a family with a biologic child earlier. What can we do during chemotherapy to minimize damage to the ovaries? One common strategy is to use a monthly injection to shut down the ovaries and to reduce premature ovarian failure, which is defined as no periods or having postmenopausal level of estrogen 1 or 2 years after chemotherapy. This cartoon shows that there are multiple primordial follicles that a woman is born in their ovaries. Over time, each one matures on a monthly basis with chemotherapy. there are more damages, but with a GnRH agonist injections, some of them may be protected. More than 10 clinical trials using this approach had been reported with conflicting results, but the general trend points to a potential benefit of ovarian protection during chemotherapy to prevent premature ovarian failure. We need to be clear here that resumption of menstrual bleeding does not equal to a successful pregnancy. However, without the former, pregnancy is not achievable either. In a large United States trial called Protection of Early Menopause Study, POEMS trial, 218 patients with estrogen receptor negative breast cancer received standard chemotherapy. Half of them had additional GnRHa injections during chemotherapy to protect their ovaries. The study showed with the injection, the premature ovarian failure rate was reduced from 22% without injection to 8% with injection. The study also looked at the spontaneous pregnancy rate after chemotherapy and compared with or without injections. Of a total of 105 women undergoing chemotherapy with the injection to protect their ovaries, 18% of them were able to have a successful delivery, or 3 of them have ongoing pregnancy. Which is very encouraging for some of the women who were not able to undergoing IVF for one reason or another. The National Comprehensive Cancer Network updated their guideline at the end of 2015 to endorse the ovarian protection in ER-negative breast cancer. The St. Gallen International Expert Consensus also published their guideline at the end of 2015, also endorsing this approach for fertility preservation or ovarian function protection in estrogen receptor negative breast cancer. Is pregnancy safe after breast cancer diagnosis? This is a reasonable question since 80% of the breast cancers are estrogen receptor positive. Would a surge in estrogen during pregnancy negatively impact long-term breast cancer outcome? The consensus is no. It does not impact the breast cancer outcome. A European study compared 300 plus breast cancer patients who became pregnant a number of years after breast cancer and matched to breast cancer patients diagnosed around the same time with similar age, similar estrogen receptor status, similar nodal status, and adjunct systemic treatment. The median interval between breast cancer and pregnancy was 2.5 years. The graph on the left showed estrogen receptor positive tumors. There's no difference in breast cancer recurrences with or without pregnancy. The one on the right also showed there's no difference in estrogen receptor negative breast cancer patients. Another safety concern is whether hormone injections during IVF increases the risk of cancer recurrences down the road. This study looked at 200 plus patients. 1/3 underwent IVF. Letrozole, a drug we often use to treat breast cancer, was added to the standard IVF hormone medications to blunt the estrogen surge. After 5-year follow-up, no differences in breast cancer recurrences between the 1/3 who underwent IVF and the 2/3 who did not, which is reassuring. A third safety concern is whether to protect the ovaries during chemotherapy and keep women in premenopausal state after chemotherapy will negatively impact their long-term cancer treatment. The POEM studies that I discussed earlier also showed that in ER-negative breast cancer patients, the answer is it is safe. If anything, the group that received the injection to protect their ovary had a higher rate of remaining breast cancer disease-free and had a better long-term outcome. A separate European study looked at close to 300 patients with estrogen receptor positive breast cancer, also showed no negative impact on long-term breast cancer outcome after a median follow-up duration of more than 7 years. Women often ask the question, how long does she have to wait after breast cancer treatment before she could attempt pregnancy? The answer largely depends on the biology of the breast cancer. This graph shows that in estrogen receptor negative breast cancer, although the risk of recurrence is fairly high, it peaks in the first 2 years. So it is reasonable for a woman after she get past this high risk window to attempt pregnancy after, say, 3 years. In estrogen receptor positive breast cancer, although it has a much lower recurrence risk, the risk persists up to 10 years. We know that the risk of recurrence or death from estrogen receptor positive breast cancer is roughly the same in the first 5 years and the second 5 years. Therefore, the current recommendation of duration of anti-hormone therapy is extended beyond the initial 5 years up to a total of 10 years. It is unknown, however, whether the anti-hormone therapy can be safely interrupted for a couple of years to accommodate a woman's need to become pregnant. A recently opened International Breast Cancer Study Group trial is going to ask exactly this question. The study requires a patient with estrogen receptor positive breast cancer to complete an initial 1.5 years to 2.5 years of anti-hormone therapy. Then the study allows up to 2 years of break to try to get pregnant, delivery, breastfeeding before resuming anti-hormone therapy. Up to 10 years. So the take-home message here is that the pregnancy following breast cancer is safe and is a reasonable consideration in women with early-stage disease. The extended duration of anti-hormone therapy complicates the timing of pregnancy. The embryo freezing is an established method of fertility preservation. A woman's age is a major variable to the success of this approach. Ovarian protection using a GnRHa injection during chemotherapy is safe and effective and may improve prospect of fertility.